for sure, I want to talk about tongue tie and to serve your audience on those topics. But I'm really impressed by your computational fluid dynamics. Like, I don't think enough people are using CBCT exams. I don't think they know how to use it appropriately. And I think it's like insane that people make assessments for sleep and breathing without a CT scan. I think that ENT doctors who go for tonsillar adenoid surgery without a CT scan are really walking in blind into the case. And
hopefully that's something we could talk about on this interview. Exactly.
Great. Yeah. So take it away.
Our guest today is Dr. Soroush Zaghi, a highly specialized ENT surgeon and one of the leading voices in sleep disordered breathing and airway health. Dr. Zaghi trained at 3 of the most prestigious institutions in medicine, earning his medical degree from Harvard Medical School, completing his residency in otolaryngology and head and neck surgery at UCLA, and finishing a sleep surgery fellowship at Stanford University. While at Stanford, Dr. Zaghi trained under the late Dr. Christian Guilliminault, the pioneer in sleep apnea research who first coined the terms obstructive sleep apnea syndrome and upper airway resistance syndrome. Dr. Zaghi currently serves as medical director of the Breathe Insitute in Los Angeles, where he leads a team providing comprehensive functional and structural treatment options for both pediatric and adult sleep and breathing conditions. His clinical focus centers on this treatment of tongue tie, nasal obstruction, mouth breathing, snoring, and sleep disordered breathing. Dr. Zaghi is a prolific researcher with over 97 peer-reviewed publications spanning neuroscience, head and neck surgery, and sleep medicine. He is also an invited lecturer, author, and journal reviewer in his field. So thanks again, Dr. Zaghi, for taking the time.
My pleasure. It's so great to be here with you and to be able to have this conversation with you.
And your bio was pretty much correct?
I'm really honored. Yes, it was absolutely correct. And it was really nice of you to go through and to research that and to put it all together and the way you did it. I'm really humbled by it. I'm really honored by the opportunity. And I'm really grateful for the audience that we have here today.
Thanks. Well, it's a pleasure to have you, really. And yeah, there's just so many topics that we could touch on. And, your research and work has just spanned such a broad range of different areas. But maybe one focus in particular, which stood out and where you've been pioneering done pioneering research is in orofacial ties, from what I understand. So that includes the lingual tie, that one probably most of our viewers are familiar with. And yeah, I think it would be interesting just to hear from you, what's the latest on that? And, in terms of assessing, diagnosing, and also treating lingual ties. And maybe also backing up a little bit, just giving our viewers a bit of an understanding how tongue ties affect health throughout development, and maybe especially in terms of sleep and how it affects sleep and breathing.
Beautiful question. And so I think I'll start by giving a little bit of a history of how I got interested in this field and how we've developed it to where he is here today. And feel free to interrupt me if I get a little bit long-winded. But basically, I myself graduated from Harvard Medical School. When I went to Harvard Medical School, on the first day, they said to me, very importantly, this is the most important lesson that you will have in this entire school, and this is what distinguishes a Harvard graduate from everyone else. It's the fact that half of what you learn in medical school will be shown to be either dead wrong or out of date within 5 years of your graduation. The most important thing is not to learn the material, but rather to learn how to learn, because we want you guys to be discoverers. We're going to push the envelope and develop new knowledge. Currently, this was 15 years ago, they said we only know 1 to 10% at most of all the knowledge that is possible in the health sciences. So as you advise your patients, you have to go into that process with the understanding that you only understand 10%. And it's that emphasis that allowed my mind to work with individuals from different backgrounds towards improving the standard of care and learning even more about how we can help. One of the biggest problems I think we see in the field of sleep apnea, tongue tie, myofunctional, are practitioners who are stuck in the past and looking for evidence and things that are established, and holding criticism when a new treatment comes that is not quite as established. And it's really with that kind of mindset and motivation that I graduated from Harvard, that I went to UCLA Head and Neck Surgery, and that I applied for the Stanford Sleep Surgery Fellowship. And I applied to fellowship because in the fields of head and neck cancer surgery, facial plastic surgery, laryngology, there was a lot of great research and evidence and progress. But in the fields of sleep and breathing, I noticed that there was a lot of limitations, and in terms of the quality of care that we're able to provide to our patients. The treatment is all too often very segmented. So when you're talking about facial plastic surgery, head and neck cancer surgery, that's one specialty dealing with it. But when it comes to sleep disordered breathing, it's multi-specialty, maxillofacial, dentistry, myofunctional, speech. And so it takes a more multidisciplinary and holistic perspective. So it's with that aim that I went to Stanford, and I got to experience all this and meet Dr. Christian Guilliminault. I'll pause there, see if you have any questions, and then I'll go on with the story.
Yeah, I think you can go on. That's really helpful as a background to understand your journey a bit. Yeah, for sure.
So from there, with that kind of mindset, having had this research focus, having published like 15 articles in medical school, 30 by the time I graduated residency, I went to interview at Stanford, and I got to meet amazing faculty, among them Dr. Christian Guilliminault, but I also had some research mentors in the form of Dr. Macario Camacho, Dr. Stanley Liu, Dr. Robson Capasso, Dr. Riley, and Dr. Audrey Yoon. And so I got accepted to the fellowship my third year of residency, which was a little bit early. And so I knew I was going to go into that fellowship. And so the last 2 years of my residency at UCLA, I spent doing research with the group out of Stanford. And so we did a series of meta-analyses with Dr. Macario Camacho on tonsillectomy for sleep apnea, on maxillary mandibular advancement surgery for sleep apnea, for nasal surgery, for rapid palate expanders. And one of the topics that we chose was myofunctional therapy. And at that time, myofunctional therapy was not very known. And there was one guy who was talking about this therapy, and even though there was no evidence, he was like really pushing it. And his name was Dr. Christian Guilliminault. And so Dr. Guilliminault at that time had built on research that was done in other countries, including Brazil, Europe, and France in particular. Understands a long history, over 100 years of interventions led by amazing dentists and speech pathologists in the form of Alfred Paul Rogers and Dr. Garliner and others who came up with these exercises for the treatment of oral dysfunction. And work by Esther Bianchini at the time showed that myofunctional therapy could help actually improve sleep apnea. And Dr. Guilliminault was extremely fascinated by this work that came out of Brazil. And he found some exercises that were in a French book, and he started implementing them at Stanford. And people thought that this guy had lost his marbles, okay? Yeah. Whereas we were talking about CPAP and mandibular advancement and surgery, here's this old man obsessed with the tongue and the frenulum, and they kind of put him on like emeritus status, which means that he always needs a fellow to supervise him. He's not 100%. Respect him, be careful. And when you go there as a fellow, they would pull you aside and say, we have Dr. Guilliminault here, but he's not the head of the department for a reason, okay? Any study that he reviews, anything that he sleep study has to be supervised by someone else, okay? And watch out for him, because he's saying some quirky things about the tongue tie, about myofunctional. So just be careful, okay? Just be careful. Yeah. And I literally got a phone call from a sleep surgeon, and I got too close. He's like, you're getting too close to this guy. You're taking him too much at face value, okay? Be careful in terms of listening to him, all right? And so I took that, and I was like, you know what? Let me hear him out. And he was sharp, sound of mind. He had publications to support it. And yes, his idea was bizarre, that you could use exercises to help with apnea, that the lingual frenulum, that releasing it would help, whereas you would think that releasing it would make the tongue fall back. But he had done his research. And keep in mind that this is the man who discovered sleep apnea, who discovered UARS, who discovered maxillary mandibular advancement surgery. Okay,
Oh,
he's the one who went to some oral surgeons and said, you're an oral surgeon, you got to be bringing things forward. He's the one who inspired Ease and Marpy. He said, you got to expand the maxilla. Okay. I'm so lucky that I got to sit there, and he gave me a manuscript of data from this university, 300 data points, looking at tongue tie as the frequent phenotype of pediatric OSA. Okay. And no one else wanted to touch the database because they thought this guy was crazy. Like, there's like no way that that's possible. But I heard him out, did the stats, and I was really impressed. I got the articles, I read them, and then myself, Audrey Yoon, and Stanley Liu, we respected him so much, and we were his students and really learned everything from him. And really, that's where I got my inspiration to build the Breathe Institute on his guiding message that it's really with the power of imagination that we'll be able to transform medicine from a system that treats diseases to one that prevents them. So Dr. Guilleminault would postpone our jaw surgeries with me and Stanley in the morning to book 1, 2, 3, 4 tongue tie surgeries. And imagine the humility of Stanley Liu. He is an oral jaw surgeon. He does trauma surgery. He does facial reconstruction. Okay.
Right.
And here's this old guy telling you that you have to postpone your 4, 5, 6 hour case, okay, to do a tongue tie surgery, which is, you ask ENTs, they're like, that's like beneath you. That is like below me. But we researched it and we studied it and we started doing tongue ties in the OR, and I took a deep interest in that. I'll pause and I'll see if you have more questions before I continue with my story.
Wow. No, I love the story so much, Dr. Zaghi. I had no idea about these things. I think most people haven't, obviously. So, but we just know that Dr. Guilleminault, he's an icon of a man. And
icon of a man who went through his own struggles. When he discovered sleep apnea in I think it's like the 1950s, when he discovered it, he pushed the paper, he published it, and they laughed in his face. They said, "You're making this up." We told him there's no such thing as sleep apnea. Think about that.
Really?
Think about that.
Wow.
Okay. And so,
what was he basing his data off of? Was it sleep labs already, or was it something
how he discovered sleep apnea?
Was observing?
I'll take a detour, tell you how he discovered sleep apnea, and then I'll come to the story of how we push tongue tie.
Really quick.
Sound good? All right.
Sounds great.
So the way that he discovered sleep apnea is that he is a broad learner. Very well read, knows are the articles, what year they were published, what journal, where they are. He has stacks of them, but he had them filed in his brain. That means that you could sit with him and he would cite you references. This journal, that journal, this. He knew all the articles, like, like the files in your house, or like where, I don't know what. And he would learn everything. He was multidisciplinary. The problem is that ENTs only go to ENT conferences with other ENTs. Dr. Guilleminault was a psychologist, neurologist, was a psychotherapist who learned neurology, who learned about sleep and breathing, who learned about cardiology, who learned about maxillofacial, who learned about ENT. Okay, so he was first interested in dreams, okay, and the neurological aspect, but he didn't let his specialty limit him in that regard. So anyways, he goes to a conference in Italy where they're talking about people who develop nocturnal hypertension when they snore. That means that when they snore, okay, they develop high blood pressure. And he thought it was fascinating. And instead of saying, there's no evidence for this, there's no research for this, it's just a case report, this isn't high level, there's no randomized, it's not true. He said, that is fascinating. Let me go and research with my own eyes. Let me go and make observations. So he persuaded 2 cardiologists to stay up all night at the VA hospital, Palo Alto, and look around for people who snored. And he found people who snored, and they found that they would sometimes stop breathing. And they would measure their blood pressure when they were breathing, and when they were stopped breathing, and they would notice not only elevations of the blood pressure, but also arrhythmias. And they would go in the cardiology lab, and these people who had arrhythmias that they couldn't treat with medicine, so treatment-resistant arrhythmias and tachycardias, and they said it's because of their breathing. And Dr. Guilleminault came up with the first treatment, which is a tracheostomy. So he had a surgeon
Yeah.
trach these patients and show that when they are trached,
Yeah.
no
Wow.
more
Okay.
arrhythmias. Okay. And he showed it.
Okay. Yeah.
And so that's how he discovered sleep
Very
apnea.
effective
And
treatment.
that's
Yeah.
how
Yeah.
airway was discovered.
Hmm.
Yet, even though tracheostomy
Wow.
cures the sleep
Huh.
apnea, it causes hyperventilation, it causes
Yeah.
anxiety and depression, and it's not well tolerated. So from there, they went to CPAP, they went to tonsils and adenoids, they went to jaw surgery, they went to palate expanders.
Yep.
And then they found that even if
Yep.
in a kid, because he cared more about kids than adults, because the adults, you know, they serve their time, but the kids have the future. So he really felt pain for the kids.
Yeah.
And the last 10 years of his life,
Sure.
he was focused on pediatrics. And he found that if you remove the tonsils and adenoids, you do a palate expander, it still relapses unless you do myofunctional therapy. That means you can go through all the structure, but until you address the function of the mouth and the jaws, these kids will have the sleep apnea improve and then fall back.
Yep.
And so this really gave birth for us at the Breathe Institute to invest in working with a series of myofunctional therapists, ranging from Joy Moeller to Barbara Green to Sandoval Pinkerton. I traveled around, went to IAOM, I went to every conference, learned the myofunctional therapy myself, worked with a bunch of myofunctional therapists to figure out the pearls, pitfalls, history, best techniques, best practices for tongue tie as it applies to sleep and breathing. And one of the limitations of myofunctional therapy are, of course, if you have nasal obstruction, and if you have tongue tie. If you have a tongue tie, you won't be able to keep your tongue to the roof of the mouth where it needs to be in order to develop negative intraoral pressure to keep the tongue up. When the tongue is down, especially the middle body of the tongue, you're sleeping on your back, you can choke on your tongue. So what we learned is we first prepare it with therapy, we release the tongue tie, and the tongue goes up to the palate, and it's not releasing the tongue tie, but the fact that the tongue is up, that is a marker of success. So if the tongue stays up all throughout the night, you will have improvements demonstrated on objective measures. Now, to get the tongue in the palate, at least 3 things are necessary. The myofunctional, we call it tongue tone, the tongue tie, and the tongue space. So we say tongue tie, tongue tone, tongue space. And if you don't have enough space, the tongue still won't fit in. And as you asked me about the research, we talk about problems that limit the tip of the tongue and the blade of the tongue is called anterior tongue ties. And problems that affect the middle body of the tongues are called posterior tongue ties, better known as mid-tongue restrictions. And we came up with a classification scheme to do this. And I talk about the classification scheme and I talk about the evidence. If you want to look up YouTube, Dr. Zaghi, tongue time lecture, I just gave a keynote address in Switzerland, which was a real honor of my life because I had 600 practitioners there from all over the world. And I gave a keynote honoring the legacy of Dr. Christian Guilliminault and talking about the state of the art. So that is on YouTube. If some people want to check it out, you'll put a link to it. I think your audience would enjoy listening to that to get the rest of that meat.
Absolutely. Yes, we'll put that up for sure.
So,
no, this is, super helpful. And so you mentioned, you know,
so I'll just go on and say that you know, what we did at the Breathe Institute is we first developed mechanisms of identifying if it's a tongue tie, if it's not a tongue tie. We developed mechanisms of the best exercises to look for. A lot of time people will compensate by using their neck or jaw structures. We have a terrific program. It's called Myo Masterminds, where we educate and train myofunctional therapists from all over the world. We now have 500 therapists who have participated in that 9-month curriculum. And by educating these people, the quality of myofunctional care has really elevated. And now the tongue tie procedures we do are less invasive, more precise, more predictable. And we're still refining that technique, but we're also exploring other modalities and pitfalls such as problems with hypermobility, as well as better utilization of CBCT scanning. That's a research focus of mine to diagnose, especially as you go into like AI. I don't see why you wouldn't be able to input history, clinical exam based on the FAIR-6, plus the CT scan, plus the video of the child sleeping, throw it in a machine and it'll give you the result of, you know, what to do and things like that. So I really think that the work that you're doing with analysis of CBCT is very meaningful. Again, the CBCTs have to be done according to a specific protocol for it to be valid. That involves lips closed, tongue up, nasal breathing, okay? And so we instruct the patients for horizontal visual access, swallow once, let your tongue go where it naturally goes. So don't do a suction hold. Don't do that. Just natural tongue position, mouth closed, horizontal visual access, teeth together, take the scan. If the scan is done in like altered head neck posture or chin rest or weird things, the CT scans are not valid.
Right. The pharyngeal airway, the size will be completely
we've
different.
shown that if you put your head up 5 degrees, it opens it up 25%, 10 degrees, 80%, 15 degrees, 140%. So a CT scan like this versus CT like this are not comparable.
Right.
Yeah. I'll give you one more and let you ask questions, okay? I'm overwhelming you and your audience, and I don't know if this is going to be a good podcast, your best podcast, or your worst podcast.
Oh, this is great.
Yeah.
This is great.
Okay.
Keep going, please.
So another thing with CBCT scanning that people think is that, oh, you're going to do a MARPE, you're going to do jaw surgery, your airway's going to get bigger, okay? You would think that, but that's not always true. That's not true.
Okay.
What our research has found is that when you do a MARPE, do palate expander, and let's say individual has forward head posture, what happens is the posture goes back, okay? So the airway size often stays the same or it's slightly adjusted, but the posture improves before the airway dimensions do.
Sure.
Similarly, when you extract premolars, there's no change to the airway size. What happens is the head neck structures come forward. Therefore, assessment of posture with the nasion-basion C3 angle, as well as other angles in the cranium and reflect the issue more than just the airway size alone. So we have to, even when we're looking at the airway, look at the structure, volume of the airway, and the fluid dynamics, of course, but also the posture that is required to maintain that airway.
That makes a lot of sense. So to summarize, and correct me if I'm wrong, it's the reason why expansion doesn't always lead to a larger nasopharynx, or I guess that's the most likely area it would affect in your pharyngeal airway, is because the head posture will change after expansion. It'll become more, let's say, normative of what it should be, a healthy posture.
Exactly.
So that forward posture that we use to correct for the narrow airway, we do less of that then.
Exactly. Okay. And also when you're looking at the airways, it's not only the size, but also the dynamics. So I think fluid dynamics is more important than cross-sectional area, because the fluid dynamics shows that if you have like an hourglass shape, it's going to be worse. Whereas if you're more cylinder shaped and small versus cylinder shaped and big, I would rather have a small cylinder than a narrow, like wide, narrow, wide. Wide, narrow, wide is the worst airway. Okay. If you're all narrow, it would be, a little bit better, less collapsible. But I'm sure you know that in your you knew that.
It's fascinating you're bringing it up, and I wish we could open that can of worms and just talk about
so
this.
You want the airway to be the right size, okay? If it's too small and it has like a pinch shape, the air goes in and it sucks in, okay? That's one. Number two, if it's too wide, let's say you do MMA surgery, make it like wide, or MARPE, make it too wide, okay? Now you lose negative intraoral compartment pressure, which means that the jaws have to squeeze the tongue and the tongue squeezes back on the jaw to maintain suction. If you make this too wide, huge, the tongue has nothing to grip on, okay? And then it will slip back. So if the airway is too large and it doesn't have an anchor point, it will also collapse. Finally, the soft palate should be touching the tongue base. If there's no soft palate contact on the tongue base, the tongue will slip back more until the contact is made. Okay? Does that make sense? So to say that it's not just about the size, not just about the volume, there's multiple considerations, and the tongue needs to be snugly in the palate. If the palate is too wide, if the palate is too forward, you will still get airway collapse that's potentially not adequately measured in the CFT model.
This is fascinating. And I would love to talk about this more. I mean,
I'm here to support you, and hopefully we can do research on this and make this more mainstream. But that's why I wanted to take your email, because I see that you're very academic, you're very dedicated to this, and truly the answer to these things is not going to come from the PhDs and the university professors. It's not going to come there. It's going to come grounds on the boots, people like yourself who have a real dedication, who have a real interest, who are truly invested in shaping this field forward. And it's a true pleasure and honor of mine to support you in this mission.
Dr. Zaghi, thank you so much. I really appreciate those words. Yeah, I guess I can say, you know, it's kind of easy to be dedicated when you have a lot of skin in the game, literally, you know, your health kind of hinges on it. But yeah, you know, the reason I got into CFD was I was trying to fill a gap, which in knowledge and information that I needed to help inform my own treatment. And now I just have so much fun with it. You know, I'm seeing the things that you described, for instance, this hourglass shape of an airway in so many cases, not all of them, but many of them. And it just makes the airflow dynamics so much worse. And that, yeah, it's so much more complicated than we think, you know?
Absolutely. It's multifactorial, multidimensional, right? It's like 4 or 5 dimensions, right?
Absolutely. And just sleep apnea in general. And that I've realized we've barely scratched the surface of what Dr. Giulleminault, found, but there's so much to discover. And so it's actually pretty fascinating stuff.
Yeah. I think one message I'll give to your audience is that this is not linear. And a lot of other doctors are looking for like a linear relationship. And anyone who is trying to look for like a cause and effect in sleep and breathing and doesn't understand that it's multidimensional is going to be very limited in being able to give you a proper recommendation or a proper treatment. They really have to look at this from a maxillofacial, ENT, myofunctional, physical therapy, hypermobility. You have to really look at all these different dimensions. And then there's another dimension of arousability, which is cognitive and neurological as well. So you really have to kind of weigh all of these, understanding that there are certain phenotypes, like certain like classes where people fall, but there's also exceptions. And so for the exceptional cases, like for example, I do drug-induced sleep endoscopy to figure out, hey, what's the exception to the rule in this case?
You know, you're really taking the words out of my mouth. I was trying to like get into these kind of areas of topics to talk with you about, and you're saying it on your own. So I love that. And
you did give me an email that said what you wanted from the podcast. So I think I'm kind of taking the words. I'm taking your questions away, and I hope that's okay, and your audiences don't mind.
Great. I don't have to say much.
It's more of a monologue or a speech than an interview, but just for your audience, he wrote me a really nice introduction, questions that he had, and what his audience would want to hear from, which is why I'm able to, construct a story like that.
Yeah, absolutely. And you're just good at it. But you mentioned, the interdisciplinary aspect of needing to take an interdisciplinary approach to sleep apnea. And I think that is so important. And it's part of the reason I believe why so many people, especially with UARS, fall through the cracks, in diagnostics, they're not even caught themselves. But B, also why treatment often fails. It maybe less so for OSA. I mean, that's a difficult condition as well to treat, but UARS in particular, just because it does seem to have this extra dimension of perhaps neurophysiological aspect, which is more pronounced than in OSA, perhaps this overexcitability or something with the nervous system that needs to be addressed as well, in addition to the airway components, which have their sub buckets as well, like you had mentioned.
Beautifully said.
Yeah. So it's not just about the airway, like you said, it's also about.
There's one, but then there's the arousability and the collapsibility and the entire picture together, absolutely. And the compensations they do, because there's some people who are able to compensate by sleeping on their side or their neck, but if they have some physical injuries, then they won't be able to sleep on their side, to sleep on their back, and then they're really torn. Other individuals have something that we've seen for sure, which doesn't have a term for it, but it's like a post-traumatic stress disorder from their sleep apnea that we 100% see that hasn't been well termed. And so what this is kids or adults who've had a long history of sleep apnea, who have been woken up in the middle of the night. Or I also have individuals who have perfect airways, but who were traumatized in the night, either sexually or abused as a child, who have a very low arousal threshold, which means the smallest thing will wake them up. And you really have to distinguish, because those cases respond very well to psychotherapy, to NMDR therapy.
Amazing. And these are things that you offer here.
EMDR.
EMDR, which for the viewer stands for?
It's eye movement desensitization and reprocessing. And so sometimes when individuals, when you go to sleep, The purpose of sleep is for you to reorganize your memories and your dreams and ideas. And where that happens is particularly during REM sleep. Stage 3 sleep is necessary to heal the body. REM sleep necessary to heal the mind. Now, in individuals with sleep disordered breathing, UARS, during REM sleep, your whole body's paralyzed. So when it goes into paralysis, your tongue drops back a little bit and it threatens you. So as you're trying to process these memories and thoughts, it's being clouded in cortisol, adrenaline, sympathetic fight or flight, and it can make it scary to go into that stage of sleep, such that you'll wake up even before getting to REM sleep, or you'll have very severe fragmentation of your REM, even after removing the underlying root cause of the sleep disorder breathing.
Right. That
Because
makes
it's
so
not
much
safe
sense.
to sleep. And this affects women more because women are trained to protect their young. And so when you're, postpartum, women can wake up at the smallest thing, right? And so they're easily arousable. And this is young, fit women. So they arouse before they obstruct. And even more so if they're taught that, psychologically sleep is not safe. So we have to kind of unwind and get to the root cause of that. Sometimes with EMDR therapy, form of hypnosis, other times with breathing treatments, because even if you do the psychological work, but your fascia is tight, okay? That means that your body structures, your fascia has memory in it, and the way that you breathe can be limited based on your memory. And so you can have very shallow breathing. So at the Breathe Institute, we work on breathing retraining therapy, putting the chest back, more belly breathing. We can do cold plunges. We can do red light therapy, things like this to kind of reset the circadian rhythm and reset the way that you're breathing. And we see that the arousal thresholds are modulated in that way.
Wow. Okay. I would definitely benefit from coming to the Institute.
Yeah, you should come. Where do you live, by the way? You don't want to
treatment.
disclose it. It's okay, but yeah.
Sorry, what was that?
Where
was
are
the
you
question?
from? Where are you from? Don't say exactly where you live, but where you live generally?
No, I'm in Berlin, Germany at the moment.
Germany? You're from Germany?
Yeah, I'm German American. So my dad's side of the family all live in the States.
Wow, amazing.
Mom's side
From
of the family,
Germany. Wow, I had no idea. Okay.
Yeah. But I would gladly relocate to California, LA,
Just
right?
come for a trip.
For a
I'd
little
love
while.
to have you here.
Amazing. Thank you. Because I do think a lot of what you said resonates a lot. And by the way, just for the female viewers, UARS does present more often in females. So that's interesting that you brought that up. But, a lot of what you said resonates with me because I'm pretty sure I have complex PTSD from this, having this for at least 20 years, and still not properly addressed. I went from when I was age 13 to 26 before I got it diagnosed because it's just so hard to diagnose. You are very lucky, I think, if you get a UARS diagnosis these days. So I got that far, but treatment is still a ways off. And I think, it's almost like the way I think of it, and this is a very dumbed down model, but I'd be curious to get your perspective on it. I think it reflects a lot of what you just said, that sleep disordered breathing can be thought of. I'm sure this isn't novel in any way. This is probably like...
No, but go for it. Go for it. It's helpful for you to see what you're thinking.
Yeah, just kind of, there are two main, there are many different factors, but maybe two main factors that make one more susceptible or less susceptible to sleep disordered breathing. And those factors have, subcategories as well. But one is your airway, right? Your airway health. And we can look at them as like knobs. And if you dial the airway health all the way up, you have a larger airway. On general, it can be too large, as you discussed. And the fascia, the myofacial functional health is correct. So there's that knob. You can dial that all the way up. The other knob is your neurochemistry and biology, which you can dial up to be really sensitive to any kind of flow limitations. So those more kind of subtle respiratory effort related arousals, subtle respiratory events during sleep, where every time something happens, you wake up. And I had that. I was waking up 60 times an hour at its worst. So you can have more along, very sensitive up towards the UARS spectrum, or you can dial that all the way down more towards the OSA spectrum, where, you're sleeping through, you're getting desats for minutes, desaturations in oxygen, you're waking up your neighbors with snoring, etc. And I think those two things are still so little understood. The airflow dynamics themselves, but especially the neurophysiology component. And I think you working on both of those, and trying from so many different aspects to see what sticks and what works is what we need to do. And because this kind of framework also explains a lot, because I see people who get maxillary advancements. I've spoken to many. They get their jaws advanced. They have a massive airway. They have the expansion. Their nasal cavities is big, but they still wake up and they're still really exhausted. They're still waking up at night. And on the other side of the spectrum, you have people who have sudden onset sleep disordered breathing, where they're exposed to some traumatic event or something, and then all of a sudden they're waking up 30 times an hour at night and not getting good sleep. So that neurophysiology component has to be part of it as well, that we need to look at. But what is that a good summary? I don't know.
Absolutely, yeah. I think it's definitely multidisciplinary, multifocal. But really, I want to say that I think that the way forward, in terms of how we're going to get there, is not so much a reliance on people who are already in the field as researchers, but it's people on the ground who can work with the researchers to take it to the next level. So we really have to listen to the people who are experiencing this on the ground, like yourself and the patients that you serve, because this is how sleep apnea was discovered. This is how UARS was discovered. This is what Dr. Guilleminault did. He listened to parents, he listened to families, rather than going into the textbooks and looking at a textbook and trying to find the answer for something. It's not going to be in the textbook. Yeah. The answer to these problems are in the patients who fly all over the world to sit in my office and tell me about it. And this is my main source of education, like yourself and the work that you're doing. And really the lived experience that you have had are the other 90% of the 10% of the knowledge that I got from my schooling.
Yeah. Well, we're happy to contribute however we can. The Reddit community is blowing up these days with citizens, scientists, and researchers, and it's really cool.
Incredible. It's incredible. If you just hear what's going on with the whole peptide thing, I'm sure you're really familiar with the peptide revolution and the biases that have led to these products being banned from the market, and the individuals who are taking this up and risking their lives really to kind of experiment and really. It's a tough time because you don't know if you should trust medicine or not trust medicine or where we are. And there's, right answers on both sides of the equation,
Yeah. Well, looking at the medical system, and that just reminds me a question that I wanted to make sure to ask, just in terms of your institute, how do you approach kind of a patient comes to you, let's say, how do you approach really assessing them from looking at, okay, they have sleep apnea, what type of sleep disorder breathing are we looking at, et cetera, assessing them from the ground up, and then really tailoring their treatment, because that's often, we can get a diagnosis, great, but then treatment is usually a lot of times where it gets difficult. And so just if a patient
absolutely, came to you, so we get so many inquiries who come into us, and we basically have a system of kind of like filtering through in terms of who needs to be coming where. We love to work with other providers, other collaborators. So a lot of times what we get is a myofunctional therapist who's done an excellent workup and refers the patient for a specific need. For example, hey, this patient needs tonsils and adenoids. And if it's therapist has a report, it's referred, these tonsils and adenoids, talk to the family about that. Easy, ready to go, 1 or 2 weeks, take care of the problem. Other times it's therapists who send it for a tongue tie, or sometimes a patient who thinks they have a tongue tie. And so in those cases, we have to distinguish, is it really tongue tie or is it something else? So just because the patient comes for a tongue tie, if they come from a trusted source, trusted person who's taken my trainings, who understands, we'll streamline them, get them in quickly. If it's someone who doesn't quite understand based on the way that they're questioning or answering or haven't already done myofunctional therapy, then we do a comprehensive workup. And the comprehensive workup includes a CT scan, sleep study, and a consultation with our pre-screening advisor and myself to figure out, like, where are you on this in terms of your knowledge basis and awareness of approaching it. And then if you just take a step back, people come in different kinds of severities. For pediatric, there are those who are like, okay, just need a little bit of guidance. and those will go to my wife, Dr. Nora, who's a pediatric dentist focused on prevention and dentistry and monitoring. So we'll kind of send it there. If it's like okay, kind of young, not too bad. If it's in the middle, we'll send it to our myofunctional therapist. If it's advanced needs surgery, that's when I get involved. Or I also get involved if it's a complex case. That means it's referred, something weird's going on, they can't put their finger on it. Also for adult patients, we can get different things. We can have the wife that brings in the snoring husband, and that requires one approach. And the other approach is highly educated individuals like yourself who've been everywhere, who know everything, who know more than most people they consult with. And then they
We're pretty annoying. Yeah, just kidding.
That?
Sorry, I was just trying to make a joke. Who are pretty annoying and
not annoying, underserved. Underserved. You guys are not annoying. There's just not enough. These people try to offer you a service, but they're not educated to your level, and it's very disappointing because you go to the appointment, you come out waiting for it, paying all this money, you're gaslit by someone who's supposed to be an expert who doesn't understand half of what you know.
Yeah.
And you know, a lot of you guys will sign up for the MARPE Masters course and take it, and then you go to an orthodontist and they're like, no, it's not possible to expand the palate in an adult. And you're like, what are you talking about? What do you mean it's not possible? Or, like, it's just like, so I consider it like underserved, and you guys are extremely motivated. And so when you come here to my office, it's a real pleasure to be able to meet you where you're at. And I learn a lot. I learn a lot from you guys. So you have to really see that. You can learn so much from your patients.
Wow. Yeah. Well, thanks for describing, your process and everything.
Yeah, for sure.
And I know we only have about 5 to 10 minutes maximum. And, I think you mentioned one thing, which reminded me to loop back to where we started on tongue ties, because, it is one kind of critical aspect. And I did want to make sure to ask, it's kind of like a personally informed question as well, because a friend of mine, actually my oldest friend, very near and dear to me, he had a baby 6 to 12 months ago. So it's between that age. And so I wanted to ask in part for him, but also for all the infants watching the show, and the babies out there. They also want to be served.
Yeah, absolutely.
Another bad joke, I'm sorry.
No, you're good, you're good.
So for the babies out there, he went to a pediatrician early on, and we were talking on the phone, him and me, about the baby's kind of condition and stuff. And he was saying, one pediatrician meant that maybe the baby, it looks like, has a tongue tie, but and that they should consider getting it released. And he went to another pediatrician and they said, well, tongue ties are hard to assess. Sometimes we do a wait and see approach to see if the baby will cope, it sees if it has any negative effects on the baby. And so the parents were a little bit flummoxed, right? In the end, they decided to do nothing for now to see what happens, because they also felt like intervening in the baby's mouth with this kind of surgery can be it can be tough for an infant that doesn't understand what's going on and the recovery process. There's probably minimally invasive ways to do it, but maybe not everywhere. But in any case, what would you recommend parents like that who are thinking about this? Because and maybe informed by this kind of my friend, he knows what I'm going through, that I have sleep apnea and all this stuff. And he knows vaguely there's a connection between that tongue tie and maybe there's, the growth, the 3-dimensional growth of this nasomaxillary complex, that can make you more susceptible to sleep apnea and so on. But what would you recommend to parents who are worried, about this? And this applies, I guess whatever you say could apply to adults as well. It's just they're taking care of their own tongue tie then, not that of a baby. But yeah.
I want to congratulate these parents who are really prioritizing airway health and the observation of it and the awareness of it. And I just want to kind of signal that it's not just like one event. It's not just like, oh, when they're born, you do one thing. This has to be like a longitudinal growth and development trajectory. And I think the individuals who are best equipped for providing that is not a pediatrician, but rather an airway-focused pediatric dentist who will see the baby at birth, at 6 months, at 1 year, at 2 years, 3, 4, 5, 6, all the way up, and be able to guide that growth. So I would encourage them to find a pediatric dentist who is aware of these topics, and you can test them their awareness by educating yourself. And so, my wife, Dr. Nora Zaghi, has an excellent Instagram channel. She posts every day on there where she's educating families on what to look for. So simply following that and kind of seeing some materials, following me on Instagram at Soroush Zaghi MD to kind of understand will allow you to see if you're with the right provider. But ultimately, I think it would be like a pediatric dentist who understands these concepts, who's following our research, and can at birth to 6 months look for tongue and lip ties, work on oral motor strength, transition from pacifiers to things like myomunchies to solid feeding. People who understand the role of baby-led weaning when the baby is 6 months old and can sit upright unassisted. People who can identify problems with torticollis, people who understand the role of physical therapy and tummy time and the necessity for crawling, people who understand retained primitive reflexes and can get you to the right place. So that's like 0 to 3, 4 years old is tongue ties, retained primitive reflexes, chewing, swallowing, oral motor coordination. From 3 to 6 years old, nasal breathing, chewing, swallowing, physical strength, activity, diet, nutrition, less sugar is really important. And I would say really it's up until like 6, 7 years that you're gonna, that you start to really see the branch out, that you see the origins of this problem.
Okay. So that there's kind of a key developmental period.
6, 7 years old, very critical. A lot of things changing very quickly and a lot of different focuses you have to have different times. After 6, 7 years old, you have to still keep an eye on them, but much more mainstream, much easier. Could be allergies that come up, could be poor hygiene. But 0 to 6 is like the critical period for these things. And you don't want to overtreat, don't want to undertreat.
Interesting. Okay, well, that's really helpful. And so let's say perhaps an infant does have a tongue tie. Would there be a possibility that they come out unfazed, or that, at 7 or 8 you reassess, as you're saying, this kind of continual assessment is really important? To say,
if they have a severe tongue tie that's like very tight, very effective, very restricting the mobility, causing a lot of tension, it can cause lower jaw to recess, the upper jaw to recess. So it's very obvious, palpable, and interfering with function. We recommend treatment. If it's borderline, you may choose to observe. It's really nuanced. You don't want to overtreat because it can cause reattachment and scarring, which means you go with good intentions to release the tongue tie, but now you've caused scarring, which further worsens the tongue mobility. So anytime you're going for an intervention, you have to kind of guess, if I do this intervention, it's not just doing it, it's recovering from it. Am I going to come out with improved tongue mobility, or can I come out with worsened tongue mobility? And so being nuanced in that way, there is red light therapy and near infrared light therapy, 1064 nanometer therapies, oral motor, physical therapy that should also be considered in this population.
Okay, fascinating. Yeah, thanks so much.
My pleasure, absolute pleasure.
Dr. Zaghi, we're reaching the end of our time.
Okay, excellent. Had a really great time with you.
Yeah,
great podcast.
Likewise.
I hope this is helpful. Hope someone finds this and feels inspired and learns something. Let us know. Put a comment in his chat box. Keep up the great work. Hopefully this channel grows and bring more awareness to this really underserved population, underappreciated phenomenon, and we can see more people get involved and better care for these people who really, really, really need the attention and the service.
Thanks so much, Dr. Zaghi. Yes.
Okay.
Absolutely.
Let's keep in touch. Let's push forward your research on computational fluid dynamics. Okay. Get in touch with me.
Absolutely. Thanks so much.
Okay.
We will.
See you, friends.
Let's do that.
Okay.
Yeah, you too.